Hello, everyone. Welcome to your online lecture for orthopedic assessment of the cervical spine. I am Dr. Cosby. I'm excited to be delivering this online lecture. I think the way to break this up so it's really manageable is to do a two-part lecture series, one on specific history questions, observations, and chronic injuries that might occur within the cervical spine. And then part two will be on the acute traumatic injuries to the cervical spine. And that way we can really make sure we're not spending hours on end listening to one lecture, and we can chunk it that way. As we start or venture into the assessment of the cervical spine, I think it's important to consider this kind of concept that examination of the cervical spine is going to involve determining whether there's actually injury to the cervical spine itself, or if the injury is actually to the upper limb, since we have crossover between the brachial plexus and the way that it supplies the upper limb of the body, right? So, and when I think about evaluation of the cervical spine, I think that it's one of the most complex joints that we can actually evaluate, because oftentimes the patient may actually have referred signs and symptoms to the upper limb, which will make us start an evaluation in the upper limb and miss the cervical spine injury, or vice versa. We might have a cervical spine injury that we continue to just focus on, and we might miss kind of neural signs and symptoms in the upper limb. So within the cervical spine, particularly, a more detailed assessment of the affected area is going to be extremely important, especially in the outside area surrounding the cervical spine, mainly the upper limb. So let's go ahead and get started. The first place that I always like to start with really is in the area of epidemiology. Anytime there's literature that tells us how many people suffer from a specific pathology, I think it's important to bring that into this class. And the reason I think it's important is because it will allow you to kind of identify just how many people you're actually going to see coming into your clinic, and it'll make probably this lecture a little bit more important. So what we know about the cervical spine is about 2/3 of the patient population, or 66% of the patient population, will experience some type of neck pain in their lifetime. That could be one episode, that could be recurrent episodes. But as we dive deeper into the epidemiological literature, we know that women are about 3 times more likely than their male counterpart to suffer from some type of cervicogenic neck pain in their lifetime. Additionally, those individuals that have higher stress levels or suffer from anxiety tend to suffer from or report neck pain more often than those who do not. And as we encroach upon the age of about 30, what we typically see is that there's a link between those patients who are over the age of 30 and cervical tension headaches. And that has to do with this next bullet point, which is the concept that they might be sitting at a desk, be more professionalized. And so they're sitting with that head in an anterior position. And so it is leading to sustained neck posturing or increased movements about the neck, which ultimately leads to increased reporting of neck pain over time. So what do we do as clinicians? I think this bullet point kind of really nails it home, that essentially our job is to prevent, if we can, the reporting of neck pain or neck pain in athletic individuals. And so the way that we can do that is through strengthening and stretching, and we would call this joint position sense in the cervical spine. And when we do these things proactively, then we reduce the risk of injury. Or if we do them retroactively after a patient comes into our clinic with signs and symptoms, then we can improve the symptoms, or it has been linked to an improvement in symptoms with patients in current neck pain. So as you can see, if 66% of the population is suffering from some sort of neck pain episode, you're going to have to be really good evaluators of the cervical spine. Now, let's take a stop here at the kinetic chain, and let's kind of blow this up just a little bit. We talked a little bit about this in the lumbar spine, in that each joint is either very stable or very mobile. We know, we've talked about this a lot of times, the cervical spine, when we compare it to its other counterparts, the thoracic spine and the lumbar spine, is an extremely mobile spine, right? Probably the most mobile if we look across the vertebral column. And so when we look at stability, what we're saying here is that if we have a patient with some sort of C-spine pain or neck pain, our goal most often is going to be to improve stability at the joint, right? They're most often going to be mobile. So we want to counteract that in some way, shape, or form as we look at the segments of the actual spine itself. So keep that in mind. On the next slide, what I want to give you really are kind of the corrective rules of the upper extremity. In other words, if you follow these rules most often, if you have a patient who comes into the clinic with neck pain, you've pretty much problem solved a lot of the issues that you might see, or you might be able to reduce the signs and symptoms of a patient who is in current neck pain. So the golden rule is that we're always going to address the most common dysfunction, which in the cervical spine most often happens to be what we call is an upper cross syndrome. I promise I will define that on the next slide. But we have a series of muscles that are either going to be overactive and a series of muscles that are going to be inactive. And so the tension between the two displaces the head in a forward position, thereby creating more tension or more force within the actual neck. So if we correct this upper cross syndrome, oftentimes we reduce the number of patients reporting to us with neck pain, or we reduce the symptoms of the patients who are actively reporting neck pain in our clinic. So, I mean, come on, what else do we need to do here, right? Okay, big rule, restore stability. I talked about this, right? Because the C-spine is an extremely mobile spinal part of the column. And so we're going to do that through rehabbing or strengthening the deep neck flexors. And this will help control that forward kind of anterior head posture that I've been referring to. And then we have to work on overactivity, right, of the upper traps, the sternocleidomastoid, and the scalene. So let's go to the next slide. I'm going to blow this up just a little bit. Here's the next slide, and here's what I've been referring to as the upper cross syndrome. So essentially what we have in an upper cross syndrome, which will cause a forward head posture, we can see that here in this image, we have tight muscles on the posterior and anterior aspect of our patient, right? And those tight muscles on the posterior segment are going to be the upper traps and the levator scapulae mainly. And then on the anterior, it's going to be the pec minor and the pec major, right? And we can see that if we have a tight pec minor, pec major, that's going to cause kind of an anterior rolling of the shoulders, right? If we have that tight levator scapulae and trapezius muscle, we can see how that would cause the head to kind of sit more in a forward-like position. And so where we have tightness, right, on one side, then we also have inhibition occurring on the muscles opposite that, right? So then on the posterior aspect, we have inhibited rhomboids, serratus anterior, and would also throw in that the trapezius, the lower trapezius and middle trapezius most often are inhibited too posteriorly. And then anteriorly, we have the neck flexors being inhibited, which goes back to the whole when we rehab, when we're trying to create stability about the cervical spine, it will become important to work on strengthening, right? We're strengthening this group of muscles, the neck flexors, and this group of muscles, the rhomboids, serratus anterior, and trap, lower and middle trap will also be a part of that strengthening. And then we're going to do a lot of stretching of these two muscle groups. And when we resolve that issue, I'm going to slide back out just a second and then zoom back into this part of the slide. When we resolve that issue, what we see is that a head that is forward, right? So a head that has been forward and is feeling more like 42 pounds on the cervical spine, then repositions itself to its normative resting position and feels more like 12 pounds. So we see a reduction of about 30 pounds of pressure being applied to the cervical spine when we just work with correcting an upper cross syndrome. So we can see how important it is to identify upper cross syndrome in our patient and then really to work with them to improve that upper cross syndrome, because we can see a reduction in load displacement about the cervical spine. So this will become extremely important as you start to do your pre-participation examinations, creating a basic rehab program, right, where we work to prevent some of the stressors that might be applied to the cervical spine because their head is in a forward position. So now we move into the kind of patient history segment, and we're going to spend a lot of time here in the next few slides. So I apologize in advance, but the history component of the cervical spine is really an important component to allow us to differentially diagnose what's going on with our patient. So one of the history questions that we're going to ask is kind of what activities or postures will increase their signs and symptoms, right? And so we can automatically just go, okay, what are the activities? Are these activities something that is a part of the day-to-day practice of the patient? Are they pastimes? Like what activities actually cause or bother the patient? What types of postures will also bother the patient is another thing to kind of ask. What type of work does the patient do? That's going to be a big question as well, right? Are they sitting in positions all day at work that would require them to be in a forward head posture? So examples of that would be like someone who sews for a living, or someone who types for a living, right? Like we're thinking like an administrative assistant, for example. Are they working at a desk and they maybe have a desk that isn't ergonomically positioned to put their neck in the right position? Other things that we kind of want to think about, like, do they wear glasses? Because oftentimes glasses can be linked to the development of headaches, especially if they haven't maybe seen an optometrist in a very long time. So in terms of activities, we want to know, like, what are the activities of daily living that bother them, but then in general, what activities also bother them as well. And then what postures will kind of cause any types of signs and symptoms. So are the symptoms, do they occur right away? Most often that's going to be associated with like some type of bony pain, but muscle or ligamentous pain, on the other hand, can come on immediately, or sometimes it can take several hours or days for muscles or ligaments to kind of manifest themselves. How long have the symptoms been present is also another question, right, in this bullet point number 1. Long bullet point number 1, but we want to ask ourselves, how long have the symptoms been present? What we know is that like myofascial pain, for example, can last a longer period of time, sometimes can last up to 3 months. So if it's long-term, maybe you're not thinking muscle or ligament, but you're thinking something about myofascial pain. So this becomes a very important kind of question to dissect and to ask, so we know what activities of daily living are being impacted by this particular injury. The next thing that we want to think about are, what are the sites and boundaries of the actual pain, right? So you're going to have the patient point to the location or locations of pain. And so then let's differentiate this. So we have C1 through C4, and then we have C5 through T1. C5 through T1 represents our brachial plexus, right? So this is the part of the cervical spine that originates in the cervical spine, but then branches out into peripheral nerve roots, right, to supply the upper limb. And then we have C1 through C4. Traditionally speaking, patients who have injuries to C1 and C4 do not have symptoms that go into the arm. So this is a differential diagnosis, right? If a patient comes in and is complaining of pain in the arm or neuropathy or radiculopathy into the arm, then you're automatically thinking C5, T1. And if they maybe have no arm signs and symptoms, then you're most likely thinking injury to C1 and through C4. Now, the concern with injury to C1 and C4 is, remember, this is the upper cervical spine area or region, which is responsible for controlling things like heart rate, respiratory rate, or respiration, right? So we're more concerned, and injuries here are going to be more catastrophic. Injuries here are going to require us to do a kind of more thorough assessment of the patient, just because we have several nerve roots emanating or coming off of the brachial plexus from the cervical spine. After we're done, like, kind of assessing the boundaries, the next thing that we want to kind of consider is the type of neuropathy that the patient has, or the neurological signs and symptoms that the patient is experiencing. So oftentimes the patient can experience paresthesia, which is a numbness or tingling. They can experience anesthesia, which is a complete numbness of a limb, so they can feel nothing whatsoever. They can also experience what we call dysesthesia. So this is going to be more what we would define as abnormal sensations. And so you touch them, and instead of feeling maybe sharpness, they might complain of a burning, for example. So these individuals will report some type of abnormal feeling that is outside of numbness and tingling, or complete numbness whatsoever. When we think about paresthesia, anesthesia, or dysesthesia, the question that we're asking ourselves is it in the extremities or is it bilateral, right? If it's in the extremity, then we're thinking nerve root. And of course, if there are bilateral signs and symptoms, then we're thinking that something has to be impacting the spinal cord itself. And so that is going to allow us or drive our assessment a little bit more. Our next question is really about the problem sleeping, right? And this is a key one. So one of the things that we want to know from this question is, what can be learned about the patient's sleeping position? Do they have any problem sleeping? How many pillows does the patient use? What types of pillow do they use? Are they feather? Are they foam? Are they buckwheat? Like, what type of pillows? What we know about foam pillows is that they tend to retain their shape. They tend to have more of a bounce. but they don't offer as much support as like a good feather or a traditional buckwheat pillow. So those things might lead us to assume what might be wrong with the patient in terms of the generalized neck pain that they might actually be presenting with. Other things that we want to know is like, what type of mattress does the patient use? Is it a hard or a soft mattress? Is it a memory foam mattress? Does the patient hug the pillow when they sleep? So in other words, are their arms adducted, or do they sleep with their arms wide out, right? You're a bed hog is what I call those individuals. These positions, all of these positions, the different types of pillows can kind of increase stress in the cervical spine and cause peripheral nerve root pathology. So knowing these different things about the patient's sleeping patterns, the patient's sleeping environments, allows us to kind of dive deeper into their cervical pathology as well. And then talked a little bit about this, but I want to dive deeper here. Age is a big deal in the cervical spine. What we know about age is that degeneration happens within the body naturally. So as we age, there is wear and tear that occurs to the vertebral column. But in the cervical spine in particular, what we start to see is spondylosis occurs, or degeneration of the actual cervical spine. And this is present in 60% of patients over the age of 45. And then as we get older, over the age of 65, this degeneration is often present in about 85% of the population. So by the time you get about 45, you can guesstimate that you're going to have at least one spondylosis or degenerative disc, if not more than that. And then, of course, as we progress in age, the percent chance that we have spondylosis occurring at the spine grows even higher. So this is important because as we work with older patients, and maybe none of us will, but if we do work with older patients who present to us with neck pain, age is going to be a predictive factor, right? The other pathology, which we haven't talked about here besides spondylosis, is going to be stenosis of the spine as well, which occurs in patients that are older, right? In that 50 to kind of 60 age range. So next up, we have mechanism of injury, the consistency of the pain, and then history of previous cervical injury, which we'll talk about on the next slide. The mechanism of injury is pretty straightforward. Either it's acute, which means, sudden onset, or it's insidious, which means it took time to develop. It's a chronic pathology, right? In acute situations, in acute mechanisms of injury, obviously the mechanism of injury itself will provide clues to the trauma. So most often, if we see a cervical spine injury and it's acute, there's some type of axial load that's occurring to the top of the skull. And so we'll rule out fracture and dislocation. The more challenging injuries to palpate, to assess or evaluate are going to be the insidious injuries. Those are going to be the ones that take a little bit longer to develop, right? They're going to require a more thorough postural evaluation of the patient to determine the cause and effect. But common chronic pathology, stenosis would be an example. Disc pathology might be another example. Anybody want to give me anything else? A facet would be another example potentially of an insidious onset, right? So we can see these insidious or chronic pathologies, we're going to spend more time with the patient. The acute ones, most often, we're typically referring out, especially if the patient loses consciousness. So understanding, having them describe the mechanism of injury, having them describe the directionality of the force or the direction in which the cervical spine moved is extremely important. So you have to get really good at asking those questions and leading your patients to give you good answers. In terms of consistency of the pain, there's really two types. There's mechanical and there's chemical. Mechanical is, I think it's very descriptive in the way that it's defined. So mechanical refers to pain with certain movements. So mechanical pain is one in which when the patient moves, they have pain, but when they are still, they do not, right? Chemical pain, on the other hand, is a constant pain which occurs with a variety of movements, one of which could just be standing upright or with movements as well. So there are differences between the two, right? This mechanical pain is going to take a stimulus, a movement stimulus. Chemical pain, however, doesn't always take a movement stimulus. So we can think of maybe pathologies where you would have mechanical pain, and I could think of muscle, right? Ligament, mostly bony, right? And then chemical, we're thinking maybe disc, space occupying lesion, or cancer, right? And the list could go on and on. And then finally, I want to spend a little bit more time about history of previous cervical injury. So I'm going to skip a slide and go here. In the previous history, what we really want to be looking for are previous traumas to the cervical spine. So if they had previous, let's say, axial load to the cervical spine, what we typically see if there's a lot of loading on the cervical spine vertebrae, oftentimes the intervertebral foramen may start to narrow because scar tissue starts to develop because there's been so many repeated blows to the cervical spine. This, in essence, secondarily can start to impinge upon the spinal cord or the peripheral nerve roots, right? We can also see that the repetitive blows to the cervical spine, mainly axial loads, can also cause the development of osteophytes or bony outgrowths within the vertebral canal, which could then impinge upon the spinal cord. And then obviously, as we continue to load those vertebral bodies, the disc, of course, after a lot of load can start to dehydrate and herniate, further impinging the structure. So that's one example of how knowing what type of previous injury to the cervical spine is going to be extremely important. Another previous history question that we want to ask is any history of nerve injury, in particular to the brachial plexus. What we know about people who suffer from a brachial plexus stretch or a burner or a stinger, as you might all call, is that because there's such a hyper stretching of that area, the skin or the tissue is stretched, making it more susceptible to re-injury, meaning they suffer from burner and stingers more than you would like them to. And additionally, patients who have, in particular, brachial plexus pathologies may report with chest-like pain, right? And so when we think about a patient who took a blow to the cervical spine, if they do have chest pain, even if we suspect that it's C-spine, we still have to refer out and have a physician rule out any cardiac pathologies, right? Before we continue our C-spine evaluation or assessment. And then I'm going to come back to this point in just a second and move back to this slide to talk about location of pain. So the location of pain can also be telltale. You'll have the patient kind of point to where they might be injured. And either they're going to describe something that's very focal and localized, or they're going to describe something that emanates from the cervical spine into the upper arm, and that's called radiating. Our localized anatomical structures, most often patients will report local pain with muscle, ligament, fracture, dislocation, facet. And then with radiating, you already know, it's going to be spinal cord, nerve root, all of which can occur as a result of a disc pathology, for example, a stenosis would be another example, or a space-occupying lesion. Last but not least, the onset of pain is most often associated with the mechanism of injury. So they can be acute, right? Very traumatic, sudden onset, or it can be chronic or insidious, which is most often coupled with an overuse injury or some type of postural dysfunction, such as forward head deviation. Now I'm going to come back to this slide where I want to address this. C2 and C3 nerve roots in particular are most often the culprits for headache, ear pain, and occipital pain. And that makes sense. Remember, C1 through C4, you're only going to have pain mostly in the cervical spine region. It will not emanate into the axilla. So let's move here to Claward's signs. When we think about Claward's sign, he was obviously a physician who looked at referred pain patterns specific to the cervical spine. So in this particular area, we already said C2, C3, you're going to have pain just posterior to that ear. So you can see that spot there. You're also going to have pain in the occipital region. So C2, C3 nerve roots, if they're irritated, will cause pain on the posterior aspect of the skull, which will present like a cervicogenic headache. Now, of course, some patients might report pain in the neck region here, which would be a C3 through C5 kind of referred pain pattern. And then as we progress, obviously, down the cervical spine, we can see how C6 and C7 nerve roots might refer pain to the upper part of the shoulder. And then C7 through T1, we can see that's going to be more thoracic region, right on the border, the lateral border of the scapula. So even though we are assessing the cervical spine nerve roots, we can see how they might have referred pain posteriorly and also inferiorly down the spine. So we have to keep that in mind when we're working with patients. Okay, you know this from lower extremity, that observation of a patient begins the moment they walk into your clinic, and that is no different for a patient with a cervical spine injury. When we think about really looking at posture and assessing the way that the cervical spine behaves, the recommendation is that the patient is what we call suitably undressed, which means if you're a male, then you would be shirtless. If you're a female, then you would have on a bra. So when you start the observation phase of a cervical spine evaluation, you may need to move them into more of a private setting if you really want to look at the curvatures and the bony anatomy, right? Like I said, when a patient with a pathology walks in, we're going to start observing them the moment they walk into the clinic, right? Because this allows us to look at spontaneous movements that are unobserved, to see how they behave. And this will help us in our overall patient evaluation, right? Okay, so let's talk about observation and the things that we're actually going to be looking for. First and foremost, we're going to look at head and neck posture, right? The one question that we're going to ask ourselves is the head in the midline? Or is there evidence of what we call is torticollis, which is right here? And torticollis can either be congenital or acquired. Torticollis, if it's congenital, is called wry neck. And so what is this? This is a shortened, what we call is sternocleidomastoid muscle. So in a congenital torticollis, the patient is born with a abnormally short sternocleidomastoid. And so oftentimes that head is going to be rotated in the position and stuck in the position of that shortened sternocleidomastoid. Now, torticollis can also be acquired, right? Which means I slept wrong, I woke up, and now I have a crick in my neck, or I cannot move my neck, right? That's also torticollis. That happens from an overspasming of the sternocleidomastoid, which causes a shortening for a period of time. But the difference between a congenital and an acquired torticollis is the obvious, right? That with a congenital, there's surgical interventions going to be needed. With an acquired, some heat, maybe some massage, maybe some anti-inflammatories, and we are back to normal, right? Okay, other things that we want to look for in the head and neck posture area is any adaptations that they might have. So this is the time where we're going to identify if they have the upper cross syndrome, right? Do they have that forward kind of head posture? Does the head sit in the middle of the shoulders like it's supposed to do? Or is it rotated or tilted to one side or the other, which indicates a torticollis, which we already talked about, right? So main thing is the head actually in alignment? The other thing that we have to consider with head and neck posture is if it's not in alignment, is that normal for that particular patient, or is that because of the actual injury that the patient is presenting to us with, right? Next, we want to look at the shoulder levels. We know that the dominant side is typically lower, so the dominant side is going to be a little bit lower. That's because we're using it. The muscles on that side are typically more lax. So with an injury, however, the injured side may appear to be elevated, right? So you might have a spasming of the upper trap or levator scapulae, for example, or you might see the shoulders be more rounded, right? And so all of these things are considered compensations. Traditionally speaking, however, a dominant shoulder is going to be lower. That isn't always the case. You'll all prove me wrong in lab. I am sure of it. Next on the list is muscle spasm and any asymmetry. So what we're wondering is there any atrophy of the muscles of the axilla? For example, the deltoid muscle, which is supplied by the axillary nerve. Is there a palsy? Is there a torticollis, for example, or other muscles in the neck, right? So we're looking for muscle spasm. We're looking for tightness, prominence of the SCM muscle, right? All of these things are going to kind of help us become detectors. The next thing, which isn't always intuitive for students, is facial expression, right? We're looking at the patient's facial expression as the patient moves from position to position. So if we say, hey, move your head into neck flexion, we should be looking at the patient's face, right? Oftentimes they might be apprehensive, and so you'll see the eyebrows actually rise. And so observing facial expression will give the examiner kind of an idea of how much the patient is truly suffering, right? So we want to keep an eye on those things. And then last but definitely not least is we want to look at bony and soft tissue contours to make sure they're behaving the way that we would expect them to behave. If the cervical spine is injured, most often what we typically see is that the head tends to be tilted or rotated away from the pain. So let me say that again. In a cervical spine injury, the head is usually rotated and tilted away from the actual pain, and then the face is going to be tilted upward. So that's a splinting mechanism that patients will present to us like. If the patient is hysterical, if they're crying, the pain tends to be tilted toward the pain, and the face tilted down. So it depends on the type of patients. But most often, though, in a cervical spine injured patient, that head is going to be tilted, rotated away from the pain to avoid painful mechanisms. As I mentioned on the other slide, patients over the age of 30 have suffer most or report cervical tension headaches, and this is as a result of the sustained neck posturing or increase in movements to compensate for this position here, sitting in front of a computer monitor. So as we look at, as I said, we want to observe the patient in their natural habitat as much as is possible. Most workstations nowadays have sit-to-stand desk. They also have monitors with adjustable levers, so you can adjust the monitor either up or down to compensate the position of the neck or the head, right? So most workplaces are getting a lot smarter because they don't want patients to miss work because they actually have neck pain. Remember, 66% of patients are going to report some type of neck pain in their life. So we want to try to avoid that where we can and where it's possible. Next up are important differentials. As you're asking these history questions, some of the things here would be your thought process kind of as you're working through those differentials. So the first one is, as they describe their pain to you, are they describing it as an unyielding pain, or something that is more chemical in nature? No matter what they do, the pain isn't relieved. That may be a disc rupture, but we also know from previous lectures that it could also be some type of tumor, neoplasm, space-occupying lesion, cancerous lesion, etc., right? So anytime we have that unyielding pain, that's a red flag. Usually it's a stop and a refer out to rule out the worst case scenario, which in this case would be some type of tumor occupying the spinal canal. Another thing that we have to consider is that we'll have some patients who will present with, and I'm going to highlight this word here, persistent dizziness and tinnitus. And so in those instances, most often that's not C-spine related. So what we're really thinking about is if that patient is experiencing persistent dizziness or faintness, or is suffering from seizures, most often that can be associated with like some type of compromise to the semicircular canal. Remember, we have those inner ear bones, right, which control a lot of the balance that we have as individuals. So oftentimes it could just be an inner ear pathology that's causing that persistent dizziness and or tinnitus. And so we'll want to refer out just to ensure that patient isn't suffering from something outside of our control, right? And then we have differential for ligamentous trauma or neuropathy. So let's go with ligamentous trauma first. If we have a ligament, there are 3 indicators of that. First of all, the patient typically does not want to move their head. And the reason they don't want to move their head is because if there's ligamentum trauma or even muscular trauma for that matter, you'll see the muscles surrounding that ligament spasm, and then they'll have very focal pinpoint pain. So they'll be able to locate that pain very specifically. So that helps you rule in ligament trauma, right? But then we also have patients who report to us and say they have referred symptoms or referred neurological sign symptoms that don't just stay in the cervical spine, but actually go into the arm of the patient, right? Now, we have cervical radiculopathy. So what we mean by that is these are symptoms that are going to move into the axilla. And this is usually always, unilateral. It's always unilateral. So these patients will present to us and they will have unilateral deficits in both their motor and sensory upper quarter screen. Yes, so it's very unilateral, which means most often this is going to involve the nerve roots of the patient and not the spinal cord. Now, there are some times or instances where the spinal cord is actually compromised in a cervical cord injury during contact, most often acutely, but certainly can develop chronically as well. So a myelopathy is where there's actually injury to the spinal cord itself. And so the presentation is a lot different. Patient's going to have the bilateral signs and symptoms, right? They're going to present with a spastic weakness. They'll have paresthesia. And most often they will lose the inability to kind of have coordination between the lower limbs. And we see deficits in proprioception as well. So there's a lot more compromise to a patient who has myelopathy compared to radiculopathy. Again, radiculopathy, unilateral, peripheral, myelopathy, bilateral, which means more anatomical structures are going to be impacted by that. And so we have a patient who's presenting with bilateral signs and symptoms, maybe has lost the ability to coordinate the lower extremity, that is a referral, probably medical emergency. But again, all things that we can use for differentials, right? Differential between peripheral nerve pathology versus spinal cord pathology or ligamentous pathology or something outside of the cervical spine. I don't know about you all, but as I'm doing this lecture, I start thinking, man, the cervical spine is such a challenging anatomical structure to evaluate because there's so many things that can be present or can go wrong. So I've given you a lot of things to think about as it relates to history and inspection of a patient with a cervical neck pathology. So right now, the focus will be on chronic C-spine pathologies and your assessment of those chronic C-spine pathologies. There are many different chronic C-spine pathologies, and I wish I could spend all year talking about all of these. But the focus of today's lecture is going to be on spondylosis and spondylosis. A patient who presents to you with a herniated disc, and then we'll spend some time talking through stenosis. These other pathologies are indirectly related to, we'll go there, pathologies that we'll actually discuss over time, right? The only one we won't spend a whole bunch of time on, I think we get to in the acute phase of the lecture, will be the whiplash, because you do have patients who get in car accidents who will present to you in the clinical setting. So our first stop is going to be with spondylosis. This is a chronic pathology. As the name implies, it's a spondy, so it's occurring to one of the spine in the cervical spine, and alosis is a degenerative process. So spondylosis is degeneration of a spinal body, right? And this is a very general term, and we'll get more specific as we talk about progression. So spondylosis is ubiquitous. What does that mean? It means almost every 40-year-old or individual over the age of 40 will have some type of spondylosis within the cervical spine. This is most often going to occur within spinal bodies C5 through C7. The one thing that I will say is, even though we have patients over the age of 40 walking around with spondylosis, it doesn't mean that they'll have symptoms. Does that make sense? So not every 40-year-old, even though they have the spondylosis, will report to your clinic with pain, because they may have a very strong upper system. In other words, they don't have the inhibited or overactive muscles, and so they're able to remain symptomless, right? So I want to be clear, not every 40-year-old will report with symptoms, but most often, if you look at the cervical spine literature, 40-year-old and above, you have some type of degenerative process going on over time. Again, it's most common in C5 through C7, and that has to do with the lordotic curve transitioning right into that kyphotic curve, which is going to be the thoracic spine. So you have a change in the angulation of the lordotic curve, and so that's where it's going to receive most of its force, and so that's why it's most susceptible to most of the things that we're going to talk about in this lecture. So a spondy or a spondylosis is often related to cervical spine instability. So what do I mean by that? There's a positive correlation. Those individuals who have cervical spine instability or more laxity or more movement and don't have stability, right? That goes back to that kinetic chain slide. If we don't improve stability about the cervical spine and we have tons of instability or mobility, that increases the load or the wear and tear on the spondy, creating spondylosis, right? So if we identify a patient with that upper cross syndrome, the goal would be to strengthen and stretch in hopes that we would reduce the amount of spondylosis that might occur over time, right? So in that said, very well said here, failure of the dynamic and static structures to stabilize during posture and dynamic movement can increase load and cause spondylosis. So we as rehabilitationists want to be really good at identifying those and creating prehab programs for patients that might actually present to our clinic. Now, there are other pathologies that can oftentimes present like a spondylosis or give off very similar signs and symptoms of a spondylosis. That includes cervicogenic headaches, right? So it certainly could just be that a patient has a tight like C2, C3, which is causing the pain in the occiput or posterior to the ear. And those cervicogenic headaches can be independent, meaning they're linked to tight musculature in the cervical spine or a forward head posture, or it can also be linked to spondylosis, right? Rheumatoid arthritis will present very similarly to a spondylosis, right? Rheumatoid arthritis is a chemical condition which causes massive amounts of systemic pain throughout the entire body. There are patients who, when their rheumatoid arthritic journey begins, typically it will plague the cervical spine, and so it will present like a spondylosis. And so these are just pathologies that we'll have to rule out if we have a patient presenting with cervical neck pain. A progression from spondylosis is going to be osteoarthritis, right? So we have degeneration, and then we start to have degradation and tear down and breakdown. And so that develops into osteoarthritis, which when our bones get weaker and they sit on top of each other, we have something called segmental degeneration. So let's take C5. If we have C5 and we have spondylosis, the next vertebrae just distal to that, C6, is going to have to start bearing some of that load, right? Because C5 isn't capable of doing that. And then C6 starts to break down. And so then guess what has to bear the next brunt of the load? C7, and so forth and so on. So we can see that segmental degeneration that will happen over time. A disc degeneration. So what do I mean by that? Either hydration, or we've loaded the disc so much that it's starting to flatten out, can also lead to the development of spondylosis or present like a spondylosis, which would present with neck pain. Major difference between spondylosis, I think I say it on the next slide, and disc degeneration is that if the disc, as it progresses, will start to cause neuropathy, a spondylosis will not cause neuropathy. So as we progress to the next slide, let's talk through signs and symptoms of a spondylosis. So the top three, 1, 2, 3, stiffness, diffuse pain, headaches in the cervical spine, right? They will feel a frequent need to manipulate the cervical spine or adjust the cervical spine. And that's just to relieve the pain. So when we manipulate or when we traction the cervical spine, it takes pressure off the vertebral bodies and the disc. And so they have an instantaneous relief of pain. But as I said before, one of the major differentials between a disc pathology and spondylosis is this idea that there aren't any neurological signs and symptoms. And that's because the disc at this point in time is not progressing towards the spinal column or peripheral nerve roots and isn't impinging upon them. Most often we see this in a younger patient population, with women being more impacted than men, unfortunately. Women, C-spine, it's just, this is our joint. It can also be associated with some trauma or a long-term postural disorder. So a forward head disorder. You can just assume that's what I'm referring to. Forward head disorder oftentimes will apply more pressure, right? We talked about the load, the amount of pounds of pressure being applied to the cervical spine. So that makes sense. And then again, if we're taking lots of repetitive axial loads, I'm thinking about my linemen, my running backs in football, then over time, the spine just starts to degenerate, right? Now, of course, we have spondylosis, right? And then what we know is there's a progression in the spondylopathy. So we have spondylosis, which is a degeneration. Then we have spondylolysis, which is not only a degeneration, but it's a degeneration to the pars interarticularis. And then last but not least, if they continue the motion or activity, that develops into a spondylolisthesis, right? But what we see over time is a spondylosis can oftentimes can lead to disc herniation because that bone starts to wear away and the disc starts to take the brunt of the load. Additionally, if there's repetitive axial loading to the cervical spine, we can see thickening or stenotic changes that occur to the spinal cord, which leads to radiculopathy, right? If it's peripheral, it'll be unilateral. If it's spinal cord, it'll be bilateral as well. Next up is the herniated disc. Most often, if we're thinking about where it's going to occur, C6 and C7, if we go back to the previous slide, the major reason is because of the way that the cervical spine is just changing its shape as it becomes more kyphotic in the thoracic spine. So C6, C7 disc herniations are most common, and then the level above that, so C5, C6, are going to be the most common. You know the mechanism of injury. It's going to be degenerative loading over time, so that's most common, and then or age, right? But then also repetitive cervical loading, so axial loading of the head from our running backs, or those taking axial loads. We see it most often in gymnasts who spend a lot of time in the extreme ranges of motion at the cervical spine as well. So in terms of signs and symptoms, this will be a major differential between spondylosis and the herniated disc, right? So they're going to have that radiating pain. And again, the radiating pain is going to be dependent on whether or not if it's the peripheral nerve root or the spinal cord, right? So you're unilateral or bilateral. By now you should be over me saying this. We also know is that if the disc herniates enough, it's going to impact dermatomes and myotomes in the upper quarter screen, right? And so we'll have to be very specific with what level of the disc is actually injured. Now, there are different types of herniations. We didn't dive deep into this on the lumbar spine, but we'll dive deeper here in the cervical spine. You can have a soft herniation, and that makes sense to all of us, right? Soft is traditional. It means the nucleus pulposus is bulging and impinging upon the spinal cord and or the peripheral nerve roots. So that's the soft gel-like structure protruding. You can also have what we call as a calcified herniation, which it really involves more of the annulus fibrosis. So it's the hard kind of fibular portion, which is impinging upon the spinal cord. We see this most often in older patients. We see the soft type of disc bulge in our younger patients. So what are we going to do with these patients? Rest is the key. You can immobilize the neck. That's probably not realistic. That's real textbook. Now let's just really break down what we do in athletic training. We're going to do some cervical traction that can be sustained or intermittent. And even though this isn't a rehab course, we will do this in class so you all can see what that feels like. And most often we said these individuals, at least in the spondylosis slide, we said they want to do a lot of like manipulation to relieve their pain. Similarly, there has been research to suggest that patients who have a disc herniation, we want to unload that disc. And so mobilization and traction of the cervical spine has been linked to a reduction in the neurological signs and symptoms. And typically we don't do surgery unless conservative treatment is unsuccessful. So this isn't a joint where we're looking to actually go in and kind of fuse. We try to let it heal itself or resolve itself through the process of rehab. The last pathology we're going to talk about is a C-spine stenosis because it is present and you may have a patient present to you in the clinic. However, remember, we're thinking older patients are most susceptible, but there are younger patients who can suffer from it too. The etiology of the mechanism of injury is a narrowing of the spinal canal, and so you have impingement on the actual spinal cord itself, right? This can be a congenital condition. So a patient could be born with some type of space-occupying lesion, could be born with a more narrow vertebral canal, which automatically starts the stenosing process, or it could be linked to changes in the vertebrae over time. So lots of repetitive load, which changes the way the vertebrae are shaped, i.e. spondylosis. So you can see kind of progression. In addition to that, repetitive blows can create osteophytes or bone spurs, which develop in the vertebral column and start to stenose onto the spinal cord. And obviously a disc herniation will cause stenosis, particularly a grade 3 and obviously a grade 4 and repetitive injury. So what do we want to know about C-spine stenosis that we don't already know about it? In the cervical spine, it may cause myelopathy. Remember, we're thinking myelopathy is an actual compression on the spinal cord itself. And so with this, you have neurological signs and symptoms that not only impact the upper extremity, but impact the lower extremity as well, right? And so you're going to have those bilateral signs and symptoms. You're going to have those sensory deficits most often, clumsiness or inability to coordinate that lower extremity. So it's a patient who walks into your clinic and may be falling over themselves. These are all things that you want to look for. Key thing with spinal stenosis is it's the spinal cord itself. And so that patient is going to have bilateral signs and symptoms. So you'll have to do your upper quarter screen on both the right and the left limbs. That concludes this part of the C-spine lecture. Thank you for listening. I'll see you all in class.